inviting me. Yeah, I just wanted to sort of give you an overview. One disclaimer, I don't work in addictions, so I'm a neuropsychiatrist. I mainly deal with cognitive disorders, and what I put together for you this morning is what I use myself when I'm looking at someone with a potential cognitive disorder, particularly when they're young. And I'm trying to come up to a conclusion about what's happened to this person, how did they come to be cognitively disordered, what areas I'm expecting to be affected, and how I can come to a conclusion about what's going on with this person. So, of course, I am interested in addictions in themselves, and I do want to sort of talk to you about a cognitive model for addictions. So, just to check, in the audience, most of you are working in addictions?
Yeah.
All of you. So you know much more about addictions than me, just so we're clear. And the other thing is, most of you psychologists, psychiatrists and psychiatrists? Okay. Any doctor, psychiatrists? Most of you psychologists?
Yeah.
Okay, just to know what to picture. All right. So these are the areas that I want to cover. Any nurses? Nurses as well? Okay. Right. So these two I'll cover in together, basically, which is substance misuse on cognition, and the other way around, cognition on substance misuse. Okay? And how I see that relationship working. Then I just want to talk to you a little bit about alcohol-related dementia, because that's an area where we've been learning a bit more recently, and we still don't have a clear model for that, but I'll speak to you about that. And the last one is a very personal perspective about what I've seen in my clinical practice. And when you try and see what the evidence says, there isn't much there. So I just wanted to discuss that with you as well. Just put all of them together because basically you see even though they're very different substances, you see a very similar pattern there in D2 receptors. Anyway, I thought that was a curious overview. Okay, so when I say addiction as a cognitive disorder, I want to sort of give you evidence or try to convince you that these processes are affected in addiction. Learning, memory, attention, decision making, and impulse control. These two kind of, you can think of being part of the same construct, and those three are part of executive function. Yeah. The other thing is drugs alter normal brain instruction, resulting in maladaptive learning, which is what people. I try to give you evidence for what it is about drugs directly that makes you learn a particular behavior that makes you more likely to go and seek drugs. So that's one thing. So because it promotes continued use, and also the same disruption that you see there stops people from acquiring what you are trying to teach them, the things that you're working with them. So that's the barrier. The substance is putting up barriers for you to succeed because it alters the brain function in particular ways. Okay? Just wanted to put up that quote. So this is the thing, it kind of takes over the normal neural mechanisms of learning. It just shortcuts them. Because it goes directly to the reward centers that are there to try and get organisms to survive. So those reward mechanisms are there to promote behavior that supports survival, and drugs, completely subvert that mechanism. So instead of learning the things that you need to learn in order to survive, you learn to take drugs, leaving out the things that you need to survive. That's the problem. Okay? So 2 stages, if you look at a neurological view of addiction, 2 stages, yeah? So the first one is when you first start using, and that's what I was talking about. So hyperactive signaling in this particular area, reward center of the brain, yeah? So as already spoken, this leads to it rewards life-sustaining abilities. You can imagine, so eating, drinking, having a mate, all of those things are rewarded through that system. But of course, the drug subverts that, and you get these maladaptive drug-stimulus associations. Sometimes, and I'll hopefully present you with some evidence to this. What happens is basically the whole environment, in a very similar way to Pavlov's bell, right? So, classic conditioning. So you associate the environment, the paraphernalia, with the drug use. So you anticipate every time you see anything related to your drug use, triggers those memories, and once you triggers that drug-seeking behavior, makes it really hard. And then later, longer term, you've got two things going on. One, you've got this glutamine-mediated signals from the prefrontal cortex are altered. Again, that is, it disrupts your ability to control your impulsivity. So in itself, it hijacks that mechanism. And the last one is, because of the withdrawal symptoms, they are unpleasant. This is very basic, negative reinforcement. So you try to take the drug to avoid the punishment. So that's a longer term mechanism that happens then. Those are the kind of two stages, immediate and more long term. So we know from a few papers that these particular areas are affected, which is consistent with what I was telling you about what cognitive areas are affected, yeah? So, amygdala, hippocampus, memory, so reward system, and prefrontal cortex, impulsivity, executive function in general, okay? So I want to tell you a little bit about what happens in acute use, and what is the cognitive effect of that, and then longer term use. Okay? Let's cover those two things very quickly. In acute use, what happens? So if you look at both animals and humans, you largely confirm that stage 1 scenario that I was telling you about before. The evidence is consistent with that. And this is the other thing that I was telling you about. The cues that happen while you're using the substances, that gets learned, right? And then you get physiological responses just by having those cues in front of you. And it results in cravings as well. So paraphernalia, drug paraphernalia, immediately your mind is there, your cravings are triggered. That's activated. Lab animals, powerful associations, and cue response stimulus. This is my bell example. You see the things that are associated with the drug use, immediately you're craving, immediately you want to use. So it's a very powerful association, very hard to disrupt. So this is the condition-place preference. And we see here that it's been demonstrated with all of these substances. Okay? And it covers the range, as you can see. There's nicotine, there's alcohol, of course, there's amphetamine, methamphetamine, caffeine, cannabis, morphine, and cocaine. No doubt all the drugs of abuse would show a similar pattern, but these are the ones that we have good evidence for. Okay. So, what are the short-term cognitive effects of these drugs? Amphetamine, cocaine, and nicotine, as you might expect, you get an enhancement of attention, you get an enhancement of learning. This is short-term use, just so we're clear on that. Right, and there's various, I've got a few papers here that show these particular substances, show this effect. Now, opiates are usually neutral, so you don't see major impairment or major benefit. You may see a little bit of impairment. I've got one paper that demonstrates some impairment in working memory. Okay? And alcohol, it's an interesting one. Low dose probably enhances cognition and learning. High dose, of course, disrupts it, as you might expect. That's not surprising. The evidence is obviously very old and is so strong that we haven't needed to replicate it, basically. Okay, so what happens in short-term use, just so we're clear? The effects on cognition are mixed, depending on stimulants tend to promote learning, enhance attention, etc., etc. Opiates are fairly neutral, for example, and then you've got alcohol that has that mixed effect. depending on the dose. Okay, but all of them seem to reinforce the saliency, the importance of their own use, subverting those mechanisms that we were talking about earlier. You know, those learning mechanisms to promote life-sustaining behavior. So, hopefully, I've persuaded you that this supports the notion that drug use results in this maladaptive drug stimulus association that promotes its own use. Any questions on that? Are we clear on that? Do you believe my evidence?
Yes.
So why am I interested in short-term effects as a neuropsychiatrist? Less so, to be honest. You know, this is more because I wanted to just understand the model about whether there's a neurological model for addiction. You may have other models, but I just wanted to sort of put it in that framework for my own understanding, and that's what I found. This is much more interesting to me as a neuropsychiatrist, long-term use. So we've got a list of drugs there. This is withdrawal symptoms. So when you've been using them for a long time, do they have cognitive effects on withdrawal? Okay? And this might be interesting to you as the cognitive impairment that you tend to get makes it hard for you to continue to abstain. The impairment in itself stops you from being able to sort of carry out that behavior that will sustain abstinence. If that makes sense. So, got a list there. Cocaine, deficits in cognitive flexibility. Every time you hear that phrase, cognitive flexibility, they mean executive function. Amphetamine, deficits in attention and impulse control. Opioids, cognitive flexibility again. Alcohol, working memory and attention. Again, attention is part of executive function. Cannabis, cognitive flexibility and attention. Nicotine, working memory, declarative learning. Working memory is associated with attention, and again, can be thought of as prefrontal. Oops, sorry. And obviously declarative, that's episodic memory. Yeah, declarative learning. Sorry, semantic memory. So all of those, hopefully I persuaded you that deficits in both executive function, leading to impaired ability to give in to impulses, right? And memory, when you're trying to, you're teaching people some skills, some valuable skills that they need to use, their learning of those skills is impaired. So you're fighting against that when you're trying to teach these skills. Okay? And this is on withdrawal. So you're trying to for them to stop using the substances and maintain their sobriety during that withdrawal phase. From a cognitive point of view, they're very vulnerable to continue using. Does that make sense? All right. So nicotine, I think, is seen as. So we all know about smoking and lung cancer, smoking and heart disease. All of those things, I think, pretty much are accepted. But I wanted to dig into the cognitive effects of nicotine. Okay? Because it tends to be seen as a cognitive enhancer, and I'm not sure that that is true. So, you obviously in withdrawal you're going to get cognitive impairment. If it is a cognitive enhancer, you might get a cognitive. That makes sense, right? So, the thing about it is that the level of cognitive impairment that you get during abstinence predicts relapse. The more impaired you are, more likely you are to relapse. Okay. Smoking and past smoking history are linked with cognitive decline. Not that, I mean, there was a paper, and I've got it somewhere, 1991 was published saying that it may help with Alzheimer's disease. I don't know if you've read that paper. It did the rounds in the press as well, that particular paper. Yeah. Not so true. And I'll tell you why, because we try to replicate it and it doesn't quite replicate it, and then the media doesn't pick it up, so you haven't heard of it. That's a problem. Okay, so cognitive speed declines twice as much with non-smokers over 5 years. Right? And you've got, this is executive function. That is just a measure of global cognition. And ex-smokers, so there's a nice effect there. Ex-smokers are intermediate between non-smokers and current smokers. That makes sense, in their performance, right? Which leaves you to think that there's an effect there that you can recover from, but not totally, not completely. Okay. So that's the one. That's the paper I was talking about. That's the one that did the rounds. And then we still hear it to this day. I hear it from patients. Okay, but follow-up studies fail to confirm it, and there's a more recent one, 2007. It's 10 years old, but still more recent than that one, looking at high risk of Alzheimer's disease, which is not surprising because Alzheimer's disease, as you might know, is very closely linked with cardiovascular risk. The risk of developing Alzheimer's disease is closely linked with cardiovascular risk. And smoking being a cardiovascular risk factor stands to reason that there will be a link there, which is confirmed in that particular paper. And interestingly, in animal models, you see a similar effect. So lower neuron production and increased cell death, particularly in the hippocampus, particularly memory areas. Okay. Cannabis, there's less. I only know. Maybe I didn't look hard enough. But I could only find one paper that discusses this, to my liking. Impaired learning, impaired retention, impaired retrieval of dictated words and time estimation. So this was just a paper with cannabis, and I'm not sure it's all that good, that paper, to be honest, but it's all I have. Methamphetamine, there's more, there's this one paper, but it's actually quite a good paper, quite detailed, and it sort of looks at what happens 6 months, what happens later, and I quite liked it. So 6 months, you've got all of those things going on, right? Poor motor function, poor memory, all the neuropsychological deficits. And they did some imaging to sort of see what it was linked with, and they linked, those dopamine transporters that I showed you on that picture. That seems to be the link, right? And these thalamus and nucleus accumbens in particular. Interestingly, if you leave these people for up 12 to 17 months, most things come back. So that's good news, right? Most things come back, except some neurological deficits remain, and this depressed metabolism remained. So it recovered to a certain extent, but not fully. And that was about a year to a year and a half on. Now I don't know what happens after. Hopefully that's a continuing trend. So again, it's a good story for your patients, hopefully. This was a paper that mixed those two substances, which I always hate. But that's what happens in real life. You see people that use more than one substance, or you use two substances, or use one substance today and another substance tomorrow. So, okay, fair enough. So this was both heroin and amphetamines in this particular paper. Pattern recognition, verbal fluency, planning, shifting attention, those are executive. Decision making is obviously executive. And they saw similar impairment to that impairment that you see in people with a prefrontal cortex syndrome. Damage to their prefrontal cortex. Okay? MDMA for intermediate and delayed recall, so memory. This is after 2.5 years of abstinence, that test. And polydrug abusers, read the paper for yourself. It's an interesting paper. And again, the good thing about this paper in particular is that it's about real people that you might encounter in your clinic. That was good. It was not terribly selected. It was people attending an addictions clinic. But the deficits in executive function remain after up to 5 months of abstinence. Okay? Maybe a short time frame, but I think it's relevant information. Executive function, decision making, stopping yourself from using. So the periods of vulnerability, just looking at the cognition, is quite long. Which I suppose supports what happens to you in practice, that you think they're still at risk many, many years after having stopped using substances. So my summary, things to take home, right? All substances that were tested negatively affected cognition, including those, like stimulants, that seem to have a short-term positive effect. Okay? The cognitive domains that are affected are the ones that probably you care the most about. So visual spatial ability, you don't particularly care. Well, you do. Can I put my tie on in the morning? Okay. But memory and executive function for your work, those are the ones, right? Those are the ones that you really want the person to be performing well at. Memory to remember what you taught them, and executive function to be able to put it in place, to act on it when they need to act on it. So, including nicotine, I wanted to sort of highlight that because, again, I hear in my clinic over and over again, it protects. It does not. It's actually harmful. It's very clear. Okay? And these are my 2 points, my 2 clinical points. Implications for the ability to learn the skills that eliminate misuse. And of course, executive function, their ability to stop themselves from acting impulsively. This, I got interested because of the way I take my clinical history. And there was a personal reflection that I was spending quite a lot of time looking at things like head injuries in childhood, get knocked out, So it was one of my questions. Things like general anesthetic, operations. And I find myself not asking very much about. I do ask about exposure to drugs now more than before, just because of this interest. But I didn't spend any time, or very little time, looking at the prenatal exposures. So I thought, is there something that I'm missing? And it turns out I was missing. This is the obvious one, right? I did ask about this. But the others I didn't, or I wasn't asking very much about. So I thought, should I? Is it important for me to probe prenatal exposure? So you've got, obviously, those 2 things. I'm not telling you anything that you don't know, particularly the increased risk of substance abuse. Obviously, mental retardation is kind of the obvious one. These, again, nothing surprising there. This was a mixed paper, again, cocaine and opiates as well, or all of them. And the kids, compared to peers, language skills, impulse control, and visual attention, which again is prefrontal cortex, is executive. 10-year-old children exposed prenatally to alcohol or marijuana, again, had memory deficits. So he didn't demonstrate the executive deficits in that cohort. Okay. This was more interesting to me. This is the one I wasn't asking about. Okay? And I see young people, so when Matt was saying about the fact that I'm dual qualified, it means that what I'm most interested in is clinically is young onset cases, right? So this is particularly relevant to young onset cases because I see people in their 40s, 50s sometimes, yeah? So what's going on with this cohort? And we don't have lifetime follow-ups that I could find, but I think this is informative enough for me. Poor long-term spatial memory, visual motor integration, poor short attention span, delayed memory with reduced volume in those areas, quite marked in the basal ganglia, but look at that change in the hippocampus, quite massive, really, impairing learning, etc. And probably making it more likely that they'll be addicts themselves, one that would suggest. just purely from a neurological point of view. Structural changes in the parietal and frontal cortex of 3 to 4 year olds prenatally exposed to methamphetamine. For me, this is the big one, and this is the one I asked, that I wasn't asking about, and I asked about the most now. It's very extended, particularly the people I see, so 40s, their parents are in the 60s to 80s, right? And they probably smoked, a lot of them. So, in utero exposure to tobacco linked with cognitive deficits in lab animals and human adolescents. It lowers intelligence, 12-point gap. That's quite massive, right? This is middle-class adolescents, exposed and unexposed, 12-point difference. That's life-changing. It changes your trajectory. And IQ, I'm not a big fan of IQ, particularly in adults, is fairly meaningless, but in young people, it tells you something about trajectory. A little bit. Also having attention deficit hyperactivity disorder, which obviously, do you see attention deficit hyperactivity disorder in your patients all the time, don't you?
Oh, can I ask a question? Are we looking at just the mother here, or mother and father?
Mother.
No.
In these studies. I don't know. I don't know that we have a good study about what happens with fathers. Like passive smoking is what you're thinking, right? So mother's not smoking.
No, I'm wondering about.
Oh, you're wondering. Okay, you're wondering. Does it affect sperm?
Yes.
Yeah. I think the evidence is more about development in utero today, and maybe first trimester exposure in general. But I don't know. Is the answer? Is the answer? Yeah. It's a good question, actually. Good question. Because it's so massive, right? I mean, this one is I thought it was very interesting, and you might be interested. How many people see people with ADHD in their clinics? It's massive, right? Everybody.
Yeah.
Everybody's what I expect. So, times 3, your risk. It says perinatally, that's a mistake. It's prenatal. Sorry. That's the title. It's prenatal. So, prenatal exposed, this is an interesting one to consider. Prenatal exposed adolescents. So if they're smokers, they have greater visuospatial memory deficits and changes in parahippocampal and hippocampal function, versus adolescent smokers, so they're still smokers, but they haven't been prenatally exposed. So it's obviously having an effect on the smokers as well, like we will see in the next paper. So that's to try and drive the argument, but it's a double whammy. Being prenatally exposed and then being a smoker is worse than if you weren't exposed prenatally and you're a smoker. But to prove the other point, we've got adolescent smokers and non-smokers prenatally exposed. Both show reduced thickness, cortical thickness, and structural alterations in white matter, which you don't really want to see in adolescents. And then the other from lab animals, because you might say smokers, is it the nicotine or is it something else? It's kind of trying to sort of answer that question. Yeah, is it any of the things that come with smoking? So it seems that nicotine in these animal models reduces activity in the hippocampus. And it results in poor learning on those MACE tasks that they do for the mice. Learning to avoid unpleasant stimulus. Okay, so this is my summary. Try and take home. Drugs studied. The drugs studied have a clear bad effect on cognition. The cognitive deficits that we see are not neutral. They're likely to predispose people to abuse substance themselves. I was saying before, if you look at, it's not language, So if my language is affected, that doesn't necessarily do anything to my risk of addiction. I don't know if I'm making that point clearly enough. It's not language, it's not visual-spatial ability, it's not one of the other cognitive domains. It is executive function and memory. Learning. So the thing, my thought there is that is particularly troubling, as you might, so you might see this generational effect, which you might very well see in your clinics. Okay? So it breeds itself, this addiction problem, in a way, due to the cognitive effects that we see. I think is one of the mediating, I'm not going to say it's the whole thing. Obviously I'm a neuropsychiatrist, so, you know, everything, I'm a hammer, everything is nails for me. But it's not the whole story, obviously. But I think it's a component of the story. And I think it's likely to affect disproportionately particular groups of people that are already disadvantaged. So you're trapped, apart from the traps that are around you in the way society is organized, there's a biological component to that entrapment, or that captivity. Because it affects your brain in the particular ways that that is most likely to lead you down a particular path. Adolescent exposure, very important for me. Particularly because I'm looking at young adults. So, the one that we know the most about is again nicotine. And it's not the one that you see, but I think it's important because I'll get you interested in it because it's a gateway drug. From the point of view that it affects cognition in these particular ways, you might have an argument, right? And again, it's not the whole story. But it does affect cognition in a particular way that makes it more difficult. That makes it more difficult for you to resist impulsive actions. Makes you more impulsive. Adolescents who smoke, impairments in working memory, verbal comprehension, oral arithmetic, and auditory memory. So memory for words that you hear. That was the test. Interestingly, good news, it results in stopping, but working memory and arithmetic continue to be affected. We don't care too much about arithmetic, but working memory, again, is very important in an addiction context. In rats, nicotine in adolescence is linked to visual-spatial deficit, attention deficits. Increased impulsivity, increased sensitivity of prefrontal cortical dopamine terminals in adulthood. That means, again, that these rats are primed for addiction in themselves. And cigarette use linked to later depression. Okay, this is bear with me. This is a bit of a stretch. From that paper, you can conclude that because it's more likely to induce depression, and depression carries its own cognitive problems, then that is the link, as a stretch. Right. So all the drugs, less is studied, unfortunately, but we see cognitive impairment with alcohol, cannabis, and MMDA in those papers that I put up there. So my summary for the adolescent exposure. I think this kind of is self-explanatory, susceptible from insult from drug abuse, and abuse. And I hope I'm driving the argument that is something that sustains itself, at least in part through these cognitive effects that they have. And this results in long-lasting changes in affect and cognition. That's what we know from the evidence. Okay, so we've covered long-term effects, we've covered short-term effects, we've covered prenatal and adolescent and adult exposure. But not everybody's created equal. I just wanted to spend 2 minutes looking at this. And I only have one example for you, but I think it's a powerful one. So obviously not everybody reacts the same to drugs. stating the obvious there. When was the last time you sat in front of the average person? I've never sat in front of the average person. So, they all come with a different sort of background, a different set of experiences, and a different genetic makeup, and different set of exposures as well. But I just wanted to sort of give you that one example to bear in mind. The COMT gene, you familiar with this one? Mediates in part how you respond to amphetamines. It's one of the best known ones. Is one example that I can easily point to, basically. So it's an enzyme that breaks down dopamine and norepinephrine, and depending on which variety of it you have, different things happen when you're exposed to amphetamines. Okay, that's kind of that's the framing of the issue. So you've got two copies, and you have, doesn't matter what they are, but basically those are the possible combinations, all right? So you've got valine, methionine, or a mixed pair. So far so good, yeah, with me? So you can have those two different components and it results with in these combinations. If you happen to have the val combination, you do better on some of the cognitive tasks. This is a task of cognitive flexibility. Is an executive function test, the Wisconsin couch sorting task. Okay, so we can derive that with amphetamines you do better in your executive function on immediate exposure, and you see increased efficiency in performance. So you're predisposed to benefit more from a cognitive point of view from the taking of the amphetamines. But if you've got the other variants, any of us, there's no benefit. Doesn't benefit you as much. Okay? Interestingly, if you look at just testing of people, just cognitive testing of people with that particular genetic makeup, they have increased impulsivity, which is a trait associated with addiction. So hopefully this means that, or I'm trying to persuade you that somebody with the val genetic makeup is more predisposed for the stage 1 type of addiction, which would then lead to stage 2. That's what I'm trying to say. Whereas if you don't, then even if you're exposed to amphetamines, you might avoid it, because you don't get that same reward mechanism, learning, etc. That's not happening. Okay? So of course, there's other effects, but I just wanted to sort of highlight this particular point. We also know people with this particular makeup, the smokers have a greater negative effect on withdrawal from nicotine. So the more impaired. I told you before that greater cognitive impairment on withdrawal correlates with relapse. Okay, and obviously greater cognitive response to nicotine. See this, and my point is this. My point is that this is just one example that tells you that someone's genetic makeup might make them much more predisposed to becoming an addict. And I'm just trying to highlight how cognition might be involved in that mechanism. Okay. My clinical implications for this segment. I'm a clinician. I know that I'm a part-time honorary lecturer at UCL, but that's a hobby. I'm really a clinician. So this is what is important to me, I suppose. Acute cognitive effects of drugs, so I told you, are mixed. All drugs interfering with learning, in that they create a very strong association, maladaptive associations that perpetuate their own use. Those paraphernalia associations that we were talking about earlier, right? Chronic exposure has detrimental effects on cognition. The areas that we care most about are the most frequently affected. The areas that we care most about in an addictions context. An impairment of cognitive domains tend to disrupt, make it hard for the individual to refrain from consumption. Now, my question to you, after hearing me talk about this, do you do routine cognitive assessments on your patients that you see in the clinic? No. Should you do routine cognitive assessments in the patients that you see in your clinic? What would be the value of doing that to you? Yeah? Would it change your approach, or would it change your management of the addictions themselves? In what way? I mean, one thing that occurs to me, it changes your risk assessment instantly, doesn't it? So if you see more impairment in memory, if you see more impairment in executive function, you immediately might think, I'm suggesting that this individual is more at risk and may need more support, possibly. The other thing that may happen is somebody who's doing better, then you might be less worried about, and you might change your approach. That's all I'm saying. So I think it's worthwhile doing, and I think if you do a test, the areas to probe obviously are memory and executive function. Okay? So hopefully I've covered those two. And now I just want to give you an update on alcohol-related dementia, which is a very confusing area. Most of what I'm going to say comes from this paper that was published in 2013, which is a very, very good review in my opinion, and basically it's been published on the web for free for everybody to access very recently. If you want to sort of check it out for yourselves, I found it really useful to help my thinking on this. Do you care about this as addiction professionals? Because I care deeply about this. Do you encounter it? Do you encounter Korsakoffs?
Yeah.
You do. Okay. So hopefully it will be relevant. All right. So we've got in the scientific community and even in the clinical community, we've got this two syndrome. We have two syndromes and we don't know what to do with them. We've got alcohol-related dementia that people talk about, and we've got Wernicke-Korsakoffs. That's we talk about those two things. And I don't know if you know, but I don't know the exact criteria for alcohol-related dementia. No idea. I'm very clear on how to diagnose Alzheimer's, even vascular dementia. We've got a set of criteria that we can come up with, and then I can say, this is Alzheimer's disease, this is dementia with Lewy bodies, this is whatever. We make a diagnosis. With this, we don't have one. DSM-5 didn't help. We thought they were going to do something about it. Nobody's finding it helpful. The one question that occurs to many people is it possible to just have alcohol-related dementia without Wernicke-Korsakoffs? Question. Is it a discrete entity, or is it that alcohol increases risk for established forms of dementia? So there's one very strong paper published by the National Institutes of Health in the States looking at the link between alcohol and Alzheimer's disease. Do you know the result? Can you guess? There's no link. No link. No link with Alzheimer's disease. Very good, very well thought out piece of work. No link. But there is a link with vascular dementia. That's why I mention it. That's the one that that you see. And what is the relationship between AAD and Wernicke-Korsakoffs syndrome? So, the evidence for this thing that we call alcohol-related dementia If you do autopsy, people with alcoholism, all of them have a degree of brain pathology. If I had any confidence that my pictures will fit on the email, I would have put up some pictures of brains, but you've probably seen them. You know, these shrunken brains that you get in long-term alcohol misuse. And you've got white matter loss, you've got neuronal loss, and you've got real deficits in neuron density in the frontal lobes. That kind of fits with what I was telling you about the cognitive impairment that you see in alcohol, right? Interestingly, when you stop drinking, you get some changes that are reversible, so you see some new neuronal growth and some recovery in those areas, but others are not, so you recover to a certain extent. Still worth stopping, obviously, almost at any point, but there's some limit into how much you can recover. And the other thing is repeated exposure limits your ability. This recovery, how much you recover every time you relapse, that is less. If that makes any sense. Okay? That is the evidence for that idea of ARD. And do I have the neurotoxic hypothesis? So forget the thiamine, just the direct toxic effects of the alcohol. Is that what's going on? Right, so I don't have the smoking one. We don't know. These are the things that, the mechanism is to do that, maybe. Glutamate excitatory, oxidative stress, and disruption of neurogenesis. You can see direct dose-related damage to interesting areas, hippocampus, hypothalamus, and cerebellum in animal models. You see this cholinergic neurotransmission disrupted by prolonged risk intake of alcohol. That cholinergic neurotransmission, just so you know, is associated with attention, learning, and memory. So when you give someone cholinesterase inhibitors, have you heard of cholinesterase inhibitors? Is the anti-dementia drugs? What they do is they boost acetylcholine, basically. So cholinergic neurotransmission impairment results in poor memory as a general effect. And if you look at people who are eating well, they don't have anything else going on, so they're just purely alcoholic, if that ever happens, I don't know. But, they don't have anything else that you can point to. Somebody's looking after them, they're doing okay in all kinds of things. You do still see some changes. That's kind of the point. Is it due to thiamine? So forget the poor dietary intake. We know that alcohol impairs metabolism of thiamine. Okay? There's a clear link with Wernicke's encephalopathy. Have you heard of Wernicke's encephalopathy? Yes. So it's the acute state of profound thiamine deprivation that results in acute damage to the brain. It results in this delirium-like state that has a very high mortality. So the issue with that is that we now know, we have this trial that I'm not going to bore you with, but we now know that that is not how a lot of people present. And we've recently relaxed the rules to just presenting with 2 of the symptoms instead of all 3. Okay? This is 2010, yes. We changed the criteria there. So, what are the outcomes? Obviously, it's Korsakoff's of Wernicke's encephalopathy. And you see Korsakoff's when there's further disruption in those areas that I've got there. Now, the other interesting new finding about Wernicke is that it's not. So, when I say Wernicke is purely, what do you understand for Wernicke? Not Wernicke, sorry, Korsakoff's. That's what I mean. It's Korsakoff's. Memory? The thing that comes to mind is impairment in memory. Well, it seems that it's not as simple as that. And we've been characterizing the cognitive syndrome, and it includes quite a lot of executive function that we weren't detecting before. We weren't even testing very well before. So it comes with a range of cognitive impairment, not just an amnestic syndrome. It's basically the take-home message. So because we have this diversity in presentation with the whole Wernicke-Korsakoff syndrome, plus you have a distinct of what is the actual changes that you see consistently in alcohol-related, if it was just purely toxic. This has led to think that alcohol-related dementia is just a variant of the Wernicke-Korsakoff syndrome. So they're all in the same box. That's how we think about them now. So clear overlap, ARD, and chronic. So this is one interesting thing that we have some evidence for. So chronic Wernicke's encephalopathy with bowel exacerbation that don't even present. So you don't even see them in A&E. The thing about Wernicke's is that when it presents classically, it's spectacular and it can kill you. So you see them in A&E, definitely see them in A&E. But there's evidence that some people don't go that far. They may have a period of delirium and they may never go to hospital and you never see them, but they do have a Wernicke's classic pathology, not as severe. When you see Korsakoff's, you see more severe pathology. When you see ARD, it's a similar pathology, but not as severe. That's kind of where it lands. And the abnormalities found in Korsakoff's, the abnormalities found in brain, there's abnormalities found in brain regions that are beyond what you would expect if the deficit was purely thiamine. So there's other areas affected. So that's the way we think about it. So in Wernicke-Korsakoff's, damage from the thiamine, from the lack of thiamine, damage directly from the effects of the alcohol, and compounded, the effects of both compounded is what you see. And then you see a range of severity. And I think we tend to call it ARD when it's less severe and Korsakoff's when it's more severe. I think that's all that's happening. Okay? So, if you see in animal models, thiamine deficiency versus direct alcohol deficiency, very similar. Pure cases of malnutrition, I've seen one, but it doesn't progress. So I've seen one. My patient was a lady who had hyperemesis gravida. So first trimester vomiting, she couldn't keep anything down, and because she was predisposed probably, she ended up with pure thiamine deficiency in the absence of alcohol use, and it did result in Wernicke's and it did result in Korsakoff's, but there was no progression. It's not like what you see in alcohol. In alcohol, you see progression, you see more damage, and so she had a mild version of the whole thing. So there's a spectrum. Most cases have mixed pathology between thiamine and the neurotoxic effects of alcohol. That's where we landed. Okay? So that's how we currently understand it. So it's not just thiamine, there's direct toxic effects, and they're probably not separate. I don't know how much alcohol is enough. It's all over the place. What is your current recommendation? This is purely if we want to avoid cognitive effects. Huh?
Abstinence.
Complete abstinence if they're an addict. If they're not an addict,
14 units.
9 to
12 if you're a female.
9 and 12 standard drinks per week.
14 if you're
Yeah.
female. 12
So,
if you're male.
depending on how strong those drinks are,
13.6 grams.
yeah, you could slip beyond these limits. It's kind of the point. Depending on how strong they are. And I think in Australia it's a bit stronger, and then, yeah, so the advice might be different. Anyway, so those are the hard limits that I could find. 418 per week, 70 to 84 per day, cognitive inefficiencies. So 70, that would be, standard drinks would that be? 4 to 5 in a day, yeah, which is kind of tallies. So 4 to 5 in a day already, you've got cognitive impairment.
Sorry, I don't see how you can make that equation, because surely grams per week will depend on the strength of the amount of ethanol
Yeah.
in the
So-
drink.
So that is grams of ethanol.
Okay, okay, yeah, very good.
So it's just grams of ethanol.
Thank you.
To try and get away from that, I just list the grams of ethanol.
Yeah.
Yeah. Okay. So heavy drinking. The other thing to understand is this one. Heavy drinking contributes to hypertension, raised triglycerides, and increased risk of arterial thrombosis, cardiac disorders, and stroke. I think the limit was 3-4 drinks per day. 3-4 drinks per day brings forward the age at which the average age of having a stroke by 10 years. Just 3 to 4. So increased alcohol consumption, particularly after the age 60, risk to increase dementia. And I say correlation only because you don't know exactly what the causality is. Okay, and I'll talk a little bit about that, and then we'll be done. My conclusions there. I hope I persuaded you that alcohol misuse leads to cognitive impairment. 2 possible mechanisms. I think both are happening. We still don't have a clear criteria for alcohol-related dementia. Both mechanisms present clinically. All the mechanisms that could occur are vascular dementia related. And we tend to talk now about this thing, which is kind of a compromised term, again ill-defined, alcohol-related brain damage. Right? We don't have consensus criteria for that. Even in research, you see different definitions for it today. So this is just my personal discussion, and we're done. We're almost finished. You'll be pleased to hear. So, my point is, and I suppose this is less relevant for you, but just wanted to sort of think about this. Can dementia cause substance misuse directly, without any previous history of substance misuse? I cannot find anything. Maybe it's my searching. All I know is that alcohol does not lead to Alzheimer's disease, but it leads to other things. But the other way around, nobody's thinking about this. Do you see elderly patients? How old is your oldest patient? 84. What is the
The main problem was opiate.
opiate? Which is probably the mildest one, as we've seen in terms of prevention. Yeah. Okay. Have you seen anybody who started with their alcohol problem at the age of 65? Never. No. They're all much younger when they start. Okay. So I think, and I'm culpable of this, that when I'm sitting in front of an elderly person, I don't ask. I tend not to ask so much. I do ask about previous use, but I don't ask very well about current use. Of course, that's changed. I do ask now quite a lot. Alcohol doctors may fail to realize. I mean, in elderly people, what used to be okay, now it's not okay. Same things with the drug, the medication doses. You have to really adjust them. So they're drinking the same as they were drinking before, but the impact is very different. Okay? They're worse in condition, and they can make it harder to detect. And the poor reporting is not because they're hiding anything from you, but the classical way in which that presents is that they don't remember having drunk anything or done anything. So they're not telling you a lie, they just don't remember doing it. And it results in very interesting scenarios in the families. So my point to you is most forms of dementia include impulsivity, some of them as the presenting complaint, some others as something that happens later in the course. And I personally observe many cases, and that's why I'm so surprised to not find any publications, many cases in which alcohol misuse developed after the onset of dementia. After the onset. That's why in that previous slide I showed you that there's a correlation. So you might think that increases with age, and over this age of 60, resulting in dementia. Is it because they were at pre-morbid states of dementia and already becoming impulsive, already forgetting that they're drinking, already doing those things, and that's why the consumption increased? I don't know. They don't have a memory of having a drink. That's so commonly reported. So the family says they used to drink 1 glass, now they drink 4 because they forgot that they had the 1, and they carry on, and they demand more drinks. So this is a patient that stuck in my mind. This is when I first started thinking about this. 64-year-old, graphic designer, young onset Alzheimer's disease, 1 unit per day, 1 standard drink per day. That was all he drank with his meal. Half a glass of wine, that was it. So alcohol use increased to 2 bottles per day. And the interesting thing that this was enabled by the family. Because he gets cross, the bottle is there, they serve him another glass. The bottle is empty, he says, I haven't had my glass. He gets cross, let me give you another. That's what they were doing. The clinical syndrome of this person included overeating, craving sugary foods, so there was some impulsivity, some executive function disorder, even though it's Alzheimer's disease. So people younger than 64 tend to present with very atypical forms anyway. And he was very much about he saw the bottle of wine and he wanted a glass. He was very much prompted by it, which is I have to serve myself. Same thing with eating sugary foods. And I didn't know for 18 months, and then it was mentioned in passing. The patient was leaving, and the wife took me and said, "He's drinking so much; it's costing us a fortune." And so nobody had mentioned it, and I hadn't asked, to be honest. And it was increasing, and I was like very puzzled about. Obviously, young onset you can progress very fast, but I was very puzzled about the rate of progression with this gentleman. And I found out that he was drinking 2 bottles of wine per day. My question to you is this an area for research? I think it is. I hope I've proven it to you. I now always include it. And the management of that is similar to any other impulsive behavior, is what you do for all the impulsive all of that. I don't think people get... What would you do with a referral? So if I had my gentleman, obviously he's so uncomplicated that you probably wouldn't see this person, or would you? Because I don't know what I'm doing, as I told you before. I'm not an addiction specialist. So I think some of those cases I would have welcomed some expertise, and I couldn't access because of the way the whole service is set up, and because there's like a sharp dividing line, and that's probably why you don't see any referrals over a certain age. People don't think about it goes undetected, the families don't mention it, and you'd never see it. But I would have benefited from some advice, I think. Any questions? Anything?
You mentioned before that you was asking about the maybe population with the age.
Yeah, smoking.
Something that you would say.
About the relationship between addiction in general. That's what I was saying. So if you look at the cognitive profile of people with ADHD, what is the cognitive profile? The cognitive profile is very impulsive in many ways. It's inattentive and impulsive in general, which is very much about cognitive impairment in a particular area, which is frontal lobe function. So it's executive function, isn't it? So I think you're compounding it. So you start off with impaired executive function, which makes you more impulsive. Also, stimulants do make your cognition better, so you would try them. In the short term, we know that stimulants will make anybody's cognition better, but their cognition is all over the place. It will make it better. Probably they'll respond to stimulants better than anybody else because maybe they have one of those genetic predispositions to them. But over time, it compounds the problem. So I'm always, and I've done this, so I've been a child psychiatrist in my training. I was a junior doctor doing child psychiatry, and I used to prescribe a lot of methamphetamines. I don't know that I would anymore, or I would be very cautious, knowing the long-term cognitive effects that they can have. And you don't really screen for that. You screen for the symptoms of ADHD, but you don't necessarily, in a normal clinic, look at what is the cognitive makeup of this individual. So you screen for the behavior that results from the cognitive impairment, but not for the cognitive impairment itself, if that makes any sense. And my other point to you, just very briefly, is should, as part of your intervention, and I'm surprised that I didn't mention it, should, as part of your intervention, should you include cognitive stimulation or cognitive rehabilitation type interventions in addictions? Should you do that? And I cannot point to any evidence that anybody's done it, but I think it's worth looking at that specifically. So we do that in schizophrenia, some evidence that we get good results. Long-term prognosis of schizophrenia is very much mediated by cognition. And if we do address those cognitive symptoms, we do get better results in long-term prognosis. Even in dementia, or even in non-progressive, like my Korsakoffs, that are abstinent, cognitive stimulation helps a lot. Because it will target those areas that they need to reinforce to be able to learn what you, and put it in action. Those two things, learn it and put it in action. So would a cognitive intervention fit with what you do? That's my other question for you.
So instead of prescribing like Ritalin or something to an ADHD patient, what would you do instead to help them?
I'm not an addiction expert and I'm not a child psychiatrist, so I'm in a very fortunate situation. I don't know. I mean, non-pharmacological interventions would be the thing. I know that they're not available, but they do work. They're more expensive, but I think it's probably worth it in the long term for those reasons. And I've shown you that exposure to these things during childhood, during perinatally, prenatally, and during adolescencehood have consequences. So I think sometimes it's unavoidable. But I think you need to sort of, it's like when you prescribe an antipsychotic, you know that you're causing harm, you know. So it has to be a very careful decision. And I wouldn't do it in a vacuum. You also have to supplement those non-pharmacological interventions. And I think you need to address cognition as well at the same time.
But a therapeutic dose of, say, amphetamine or methylphenidate is far less than what the using.
I agree, yeah. But
Sure, Congress is very edited talk. More reasons to reject DSM. Because all we're doing is treating symptoms.
yes.
You emphasize that you've just got to use the symptoms as a guide to go back to what is the cause.
Mm-hmm.
That's what we should be addressing.
Yes, and that was a big pushback against DSM-5. But we're still stuck in the syndrome model.
Well, that's the advantage of the drug.
Yeah. I mean, yes. I think. But if you look at neurology, neurology is far more advanced in looking at final causes than psychiatry is, and I think we lost. I think psychiatry in general has evolved and is more holistic, more comprehensive than others, in that we do look at things beyond the medical model, more than other medical specialties, I would say. But we lost some of the benefits of having them gone down that track, like neurology has.
Psychologists were actually involved in forming DSM-4 or 5. No, it's medical.
I know. Yeah, but even there, if you look at ICD, is in a medical only in the medical bits. If you want to sort of speak about that, is better than in the psychiatric bits.
Just as a physician, I think that physicians really are still get equipped to treat addiction, and certainly
I agree.
be in favour of psychologists.
Yeah, I think what you need to sort of, your role is to, there's some aspects that are fairly medical, and I think you should sort of concentrate on those and leave the other bits to non-pharmacological interventions. Thank you.